All right, so let's get started on chapter 13, man. This is all about IV admixture administration as far as the dosing calculations. And if you think about, we always think about dosing, and pharmacists think about the amount of drug to give somebody, the weight of the drug, the dose of the drug. Nurses often have to be the one who have to administer those drugs. And in a hospital, since most of those drugs, many of those drugs are in an IV fluid, they think more in the volume. They don't worry about the weight of a drug, the dose and weight. They worry about how much fluid does this person need over a certain amount of time. So a lot of what we're going to be calculating are flow rate calculations, and because a lot of times they'll use drip sets, then they're going to be drops and some terminology you may not have been exposed to before that's a little bit different. So with that in mind, that is our focus. So we are going to be talking about the calculations for administering intravenous fluids. I will tell you though, you can what does intravenous mean? Directly into the vein. That's obvious. I think you probably got that down. Well, do you know what you're going to do a year from now? About a year and a half in your P2 year, you're going to learn how to compound these IVs. You're going to have to do a sterile compounding preparation, CSP, compounded sterile preparation. You're going to have to garb and gown and go into a clean room, use a hood, and manipulate your objects and get the drug additive out of the vial and stick it into the bag and do that with you don't contaminate it. So I'm getting to the point here, an intravenous fluid is water-based. It's usually aqueous, but they're sterile. There's no bacterial contamination. They're particulate-free, and they're designed so that if you bypass all of the body's defenses and put it straight into the vein, that it's not going to cause any problems. So we are talking about IV products prepared in that way. We've done a lot of calculations with isotonicity. In general, we like our products to be generally isotonic, but not necessarily, because if you look at some of these fluids on here, you're going to say those aren't isotonic fluids, and so we don't always use isotonic fluids for IVs, and part of the reason is that we cheat a little bit in the fact that depending on where we give the IV in terms of the size of the vein, the rate at which we infuse the fluid, if it's relatively slow compared to the blood volume through that vein, then the body will dilute it so quickly that maybe there's slight differences in isotonicity aren't a problem. However, there are some real considerations for that when we talk about isotonicity. Even though this chapter we won't do isotonicity, when we revisit some of this TPN, chapter 14, one of the last topics in this course, we'll do a lot on total parenteral nutrition. You're going to maybe be making these huge IV bags, 2 to 3 liters with all of these day supplies and stuff. They're super hypertonic. There's no way you could give those in a vein. Then you do a central line. You guys have ever heard of a central line? I'm just getting used to some of the terminology. That's an IV line, but instead of going out here in the vein, it actually goes all the way through and ends in the vena cava, which is your largest vein right before the heart. It has the rapid volume and blood flow and all of that, and it dilutes it really quick. So there are considerations. We do have to be aware of it, but realize a lot of your IVs you don't have to make absolutely isotonic. Also, there are a variety of different IV fluids. So we've been talking, which one of these solutions on this list should strike you as being isotonic? You should absolutely know, while not all of our IV fluids are isotonic, that one is. That one right there, that one is the 0.9% sodium chloride, right? So hopefully you all know that. What's the number for dextrose? You can use sodium chloride to make things isotonic, the 0.9%. What's the dextrose number? 5%. Awesome, you guys are good. 5% dextrose. Can you have some dextrose and sodium chloride? Sure, there's D5 half normal saline, D5 quarter normal saline. You'll see all the sorts of permutations and combinations depending on certain aspects for the patient. So those are all different solutions, though, that we tend to put our drugs in to administer them, all right? So enough of that. This is what I'd rather spend more time on, because to understand these calculations, you really have to know a little bit about how a nurse administers an IV. What we're doing are the calculations nurses need, not for the preparation of these drug products, but for the administration of these drug products. So let's start with this image over here. Let's make sure and kind of dissect some of the important things from this one on the far left. First of all, that big old kind of IV bottle there's got 2 ports at the bottom. One of the ports the pharmacist use in the pharmacy in that clean room to add the drug. Which one do they use? The medication port. So most IV bags have 2 ports. One port for the pharmacist to use to inject the drugs to add the drug to the bag. That's the medication port. But then the other port is called the infusion port. That's the one the nurse will use. The nurse doesn't want to add drugs. The nurse wants to take the bag that has the drug in it and spike it and drain the bag using this IV tubing. Okay, so we're going to talk about the tubing here in a minute. But the set the nurse uses is right here is the infusion port. Okay, so the nurse is going to use then some IV tubing. And we're going to talk a lot about these in our calculations. The tubing will determine something very important in our calculations here in a little bit. But essentially the top of the tubing has a spike. Spikes the bag, the fluid will drain from the bag and through the set. Realize most IV sets have a drip chamber, and they do that, and they'll squeeze that drip chamber a couple of times when they first spike it, suck some of the fluid down in there, and they'll half fill it. And that way, as the fluid drains down into the set, into the person, it will pull liquid and drip into that drip chamber. So as the fluid drains, it sucks fluid out of the bag and drips into this drip chamber. And we're going to talk a lot about the drip chamber here in a minute, but that's kind of where, again, you can see the fluid as it kind of flows through. So there's a drip chamber we'll talk more about, and then the tubing goes all the way and connects to the patient. Easy enough? So important things, we'll talk more about the drip chamber. The other thing I want to talk about is the Y site. Did you notice where it talks, this one has 2 Y sites. This is an important idea with a Y site, okay? A Y site is basically a place where you can connect some other solution, either a syringe or another IV bag, to that same line, okay? So you can do more than one bag through the same line to go into the patient. Why would you ever do that? So let's look over here in the middle. So let's look at this middle picture over here. This is an example here of the large bag. So you have this large IV bag that's running at a small amount all the time into the patient. Why would you do that? IV lines, are they easy to put in? Do they just slip in, or do they have to actually kind of poke a hole in you and push them in and thread it through the vein, right? So it takes a little bit of effort to get an IV line started. Some of you may have had that experience, right? It takes a little bit to get that started. If you stop running fluid through an IV line, what will happen? That IV line has a little bit of a catheter tubing that sticks out into the vein there. If you don't constantly run at least a little bit of fluid through there, what tends to happen? A blood clot. The clot forms around to that end of the tubing, and now you can't get any fluid through your IV line. You have to pull it and put a new IV line in there. Is that a good thing? That's not a good thing, right? So most of the time, most patients who have IV line access are going to have some isotonic-based solution that runs kind of at a really slow rate, kind of in constantly. Okay? Now, that can be replaced with a drug that they do need constantly, so there are certainly other reasons to have drugs that run constantly, but even if that's not the case, there's a little bit of fluid that runs constantly. What you're going to see more often then is when you have that big constant dose, would you agree a lot of patients in the hospital need to be on an antibiotic? Okay? They have an infection, something's going on with them. If they're so sick that they need to be in the hospital, a lot of times those antibiotics we want to give them are IV antibiotics. They tend to be a stronger, work faster, be a more aggressive therapy if you can give those antibiotics IV. Most antibiotics, do they have to be run continuously, or can they just be given 3 or 4 times a day? Most antibiotics taken by mouth are what? Once a day, twice a day, 3 times a day maybe? It's the same thing IV. You only have to do it every couple of hours, maybe every 6 hours or every 8 hours. All right? So that's this idea of a smaller volume piggyback. We call it a piggyback because it's a smaller volume, meaning 50 to maybe 150 mils at the most, that is going to be added onto the main line through a Y site, and they're going to run that antibiotic in maybe over 15 minutes, maybe over 30 minutes, but as soon as that antibiotic's in, they're going to remove it, okay? It doesn't need to continue to be run. So it'll be done after the 30 minutes, and the next dose will be given 6 hours later, or how many ever hours later it needs to be, okay? That's called intermittent IV therapy. Intermittent meaning you need some IV drugs, but you only need it every so many hours, okay? Versus continuous IV therapy, where you do need to have an IV product that's running into the person at some rate continuously the entire time, okay? Last thing I would say about this, and if you look at pictures or you go to the hospital next time, what is, in this setting right here, what is forcing the fluid out of the bag and into the person? What is pushing the fluid into the person? Gravity. These are gravity run sets that I'm showing you first, the first 2 on the left, okay? And in the middle are gravity run, all right? So if you've got 2 bags that are going essentially through the same line, which bag will be favored over the other? Which solution will run? Well, it has to do with which one has the greater force of gravity. So what we do on the intermittent therapy, if we want this bag to run over this one, so we want the small one to run, what you do is you take a hook and you put this hook on here and you put a hook here and you lower the big bag. You lower the larger bag down, get the intermittent therapy higher so that there's more gravity on it. The greater the gravity pull on that smaller bag will push it in advance of the larger bag. But as soon as that fluid is all gone, then the larger bag fluid takes over again. But that's why sometimes you'll see these little hook extenders off the IV poles, and it's so that you can lower the continuous infusion in favor of the smaller piggyback. All right? Now, that's all good, and that kind of relates to gravity infusion. You know the best thing ever, though, is now most of the nurses are using smart pumps. That's good for them and that's good for the patient. It helps minimize potential errors. It helps avoid some of the problems. So you can see in the example of the smart pump, we have the same two bags. We have a large volume on the left there and a kind of smaller volume on the right. But instead of having to use gravity to pull the fluid in, the pump will use peristalsis and the little wheel that turns in there and kind of pull the fluid into the person. And we can program that in there. So my last thing on this part here is just look at, I want to make sure you realize as we do these calculations, these are real numbers. These are the numbers we're doing for the nurse so that they can program their smart pump. The rate, what is the rate given there? First of all, you can see the drug on this example is midazolam. And in this case, the rate we've programmed it to be is 1.5, what are the units? Milliliters per hour. So there's a volume per time, a rate of the fluid in volume per time, that's the rate. The VTBI stands for the volume to be infused, that's the remaining volume to go in. And lastly, you can see a dose. The dose of drug the person is getting, while the volume is 1.5 mils per hour, it's 1.5 milligrams per hour. Okay? And then lastly, you can see we can program a bolus dose and so forth. So the idea is, these calculations we're going to do here in a little bit, allow the nurse to be able to program the pumps, to be able to administer the drugs at the rates at which they need to be given. So you're working together while you're formulating and compounding and labeling these products so that the nurse is going to turn around and then correctly infuse them. All right? So let's talk about infusion. The nurses for these pumps are going to need to know the flow rate. That's what they deal with, is flow rate. The only trick with flow rate is it's some volume per time. I know that seems easy, but can there be multiple different units for volume? Yes, there could be milliliters, there could be liters, there could be drops. We're going to talk about drops here in a minute. Those are all different expressions for volume. Time, can you express time in different units? Minutes, hours, usually not seconds, but minutes or hours are the main ones. So again, whatever it is, you're going to have to look at the question and make sure you can calculate the correct flow rate for the nurse based off of the units that the question tells you or what the nurse needs. So again, it could be drops, mils, it could be hours, it could be minutes. So again, you have to be careful with the units when we do these calculations. And lastly, this is an important idea for a lot of these questions, is this idea, if it's not being run by a smart pump, or even smart pumps can still be programmed in drops, most of the time gravity-fed IV products are administered in so many drops per minute, okay? So let's make sure we're clear on that. What a drop? So a drop is a drop. You know what that is. The Latin abbreviation, you have to be careful. A lot of times they'll still dose these. You'll see nurses or orders put in for GTT. So GTT, I don't even know what that stands for, but that is the Latin abbreviation, GTT, for a drop. So if you see GTT, it means drop. All right? There's two things. Make sure you don't get confused. A drop factor with a drip rate. Those should be clear in your mind. A drop factor has to do with this IV tubing. Remember, there was the bag, and then we're going to spike it with tubing, and that spike tubing has a drip chamber in it. Okay, so there are different there's different boxes of these plastic tubing. The differences between them is in that drip chamber, the thing that makes it drip, the little pin that's inside there, can be calibrated such that it gives a big drop, a big fat drop, or a little bitty baby drop. Okay, so it is the set that determines the size of the drop. So let me ask you this. If it's a little bitty baby drop, how many drops per mil would you get? Would you get a lot or not very many? If they're little bitty baby drops, you'd get a lot of drops per mil. If they're big old fat drops, then you're not going to get very many drops before you fill up a milliliter. Would you agree? So the point is, since the sets come calibrated in different pins, you get different drop factors. A drop factor simply is for that set, it will tell you how many drops per mil that set gives. Okay? So they have, for example, the micro drip has 60 drops. Those are little bitty baby drops. So 60 drops before you fill up a mil, versus the macro drip sets that you can use might even just have 10 drops before you fill up the mil. It doesn't change anything other than the fact that you got to know for that set to tell the nurse the right number of drops to use, you need to know the drop factor. Because you're going to take the drop factor and mix it in with the infusion rate. So for certain drugs, you have to infuse it over a certain time. Why do some drugs need to be infused really slowly? Because they interact. They have problems with, the formulations could have a low pH or a high pH. They could actually cause issues within the vein. Then the vein there is really narrow before it gets distributed to the whole body. So some drugs you have to administer really slowly because they cause infusion site areas. Some drugs, no problem at all. You can squish them in there really fast. So That's why you're going to see every single drug seems to have a slightly different infusion rate. It's unique for each drug. Different drugs need different infusion rates. The infusion rate, though, you're going to multiply it times its drop factor to be able to tell the nurse the infusion rate in terms of, or the drip rate in terms of drops per minute. We'll do some of those calculations here. And remember, even though, can the nurse control gravity? I mean, when I say it's gravity fed, does that mean that every gravity fed IV infuses at the same rate, at the rate of gravity? No, because there's a roller clamp on there. So the nurse will start with it closed off when she connects everything, or he connects everything. And then to get to the right drip rate, you know what they do? Is they look at the clock and they look at the drip chamber and they start that roller clamp up a little bit and it starts dripping, 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 dripping. And then they can control how fast those drips come out of there. Now the set controls the size of the drop. The nurse doesn't do that, that's the set. But the nurse with the roller clampy thing can affect how fast it drips. So the rate of the dripping is the nurse, and based off of your instructions to the nurse about how fast it needs to be administered. Okay? So with that, I think you'll see some of these. So let's just do some of these questions, but hopefully that little intro helps you understand kind of what you're trying to calculate and why we're dealing with this. Okay? So the first one is pretty straightforward. It says, what is the drip rate in drops per minute? Again, with all of these questions, on the test and everything else, double check the units, because again, you can give me the right answer, but in the wrong units, it's still the wrong answer, so be careful with that. In this case, it wants drops per minute using a micro drip tubing set that has 60 drops per mil. When doctor wants us to infuse 400 milligrams over 8 hours. Okay, so the dose of the drug is 400 milligrams, infused over 8 hours, but what's the drip rate for the nurse in drops per minute? Where do you start with this? You start with the flow rate. Flow rate in general is volume per time. What is the total volume we're trying to infuse? 400 milliliters. Over what time? 8 hours. So let's start with that. We want to infuse 400 milliliters over 8 hours. So if we set up that ratio to begin with, then we can start from there. Let's convert. We have a flow rate, but instead of mils per hour, we want drops per minute. So we could choose to change either unit. I chose to use the volume first. So let's convert mils to drops using the drop factor. So the drop factor for the set this nurse is using has 60 drops per mil. So if I multiply it by the fact that I set it up with 60 drops on top so that my milliliters cancel, I now have drops per hour. Last step is to convert the hours to minutes. So let's just multiply it by 1 hour over 60 minutes so that my hours cancel. And you can see my remaining units will be drops per minute. And if you do that math from left to right, you would get 50 drops per minute. Okay? Oh, there's no way. Anyway, let's throw it up there. So let's do that. It says which drop factor. This is kind of interesting. This kind of works the backwards. This says which drop factor, which tubing set should I use if I want to infuse 125 mils per hour. That's the rate that it needs to be, but the nurse wants to set the pump at 42 drops per minute. So in the end, we want to do 42 drops per minute. That gives us an infusion rate of 125 mils per hour. But to do that, I have to use the right set. I have to have the right set that gives me the right number of drops per mil to get that same number. So let's start with what we want. What we want is a rate of 42 drops per minute. Okay? Well, I want to get to drops per milliliter, so I don't really have to change my drops necessarily. What I need to do is convert time essentially into volume. So let's first convert minutes to hours. Since I'm in minutes here, let's multiply by 60 minutes per hour. So I'm going to change what I want to get, which is 42 drops per minute, into 42 drops per hour. Once I have my drops per hour, I can then convert from that time in hours to a volume, because I know I want 125 milliliters. How often? Every hour. For every hour, I want 125 milliliters. So now if I multiply by that so that my units of hours cancel, now you can see I have my 42 drops that I didn't really ever mess with, but now I've converted time to volume. All right, and I convert time to volume using an infusion rate. So now when you do that math all the way across, you would get 20 drops per mil, so obviously that would be the right infusion set to use, is the 20 drops per mil. Okay. All right, let's do some drugs, man. Oh, that's too generic for me. Let's do some drugs. It says, a physician orders 35 milligrams of amphotericin B and 25 units of heparin to be administered intravenously in 1,000 milliliters of D5W over an 8-hour period. Okay? So, even before we go further, there's a lot of information. I'm trying to say, okay, I'm going to group 35 milligrams with that. That's the dose. 25 units of heparin, so that's the dose of that drug. And then lastly, here's a volume. So I've got 1,000 mLs over 8 hours. Okay, so there's some important information. I got a volume, a time, and I've got my dosing. All right. The available sources of the vial are amphotericin 50 milligrams and 10 mils, and a syringe that has heparin at a dose of 10 units per mil. Okay, so I've got my active sources. And those are over here. Here you can see the vial that's got 50 milligrams, and down here we've got a heparin a syringe that has 10 units per mil. Those are my sources of active ingredient. All right, so I got two drugs. I need to pull from their original vials or syringes, get the right amount that gives me the dose I want, and putting that into a 1,000 milliliter bag. All right, so the first part is how many milliliters of each additive drug source do I need? Well, let's start with the amphotericin B. What was the dose of Ampho B? I wanted 35 milligrams. All right, so I want 35 milligrams, but my source is essentially 50 milligrams in 10 milliliters. So let's set that up down here. Set it up so that the units cancel. So there are 50 milligrams in 10 mils. So if I multiply it times 10 mils over 50 milligrams, milligrams cancel, and I get 7 milliliters. Okay? Any issues with that? That was the dose of my amphotericin B. I want 35 milligrams. It comes 50 milligrams per 10 mils, but I set it up so that my units cancel 35 times the 10 mils over the 50 milligrams, cancels my units, and I get milliliters. Let's do the same thing for the heparin. Now, should you freak out that heparin is dosed in units and not in milligrams? No, we've gone through all of that. Some drugs are dosed in international units. We treat it just the same. So what we need is 25 units. That's what was dosed. That comes from here. There's my 25 units from there. What we have is a syringe containing 10 units per milliliter. So that's what we have, and that's what we put down here. But we set it up so that the units of units cancel, and we end up with milliliters. So 25 units times in every 1 milliliter, there are 10 units so that my units cancel, and I end up with milliliters. And that math gives me 2.5. So I need 7 mils of my amphotericin B and 2.5 mils of my heparin to give me the dose of the drugs that I want. Okay? I'm going to combine those, though, right? I'm going to mix those together in a what? In a 1,000 milliliter bag and give it all at one time. So the next question says, how many milliliters of the IV fluid per minute should the patient receive, basically to get it over the 8 hours that they requested in the question? Okay? So what are we going to do? All we got to do is take volume per time. And infusion rate is volume per time. All right? The only question here is, and this is an important thing, if you've tuned me out here, and again, I know I lose you some of you for good reasons, but here's the deal. For any times, when you make IVs, you're going to be taking an active drug out of a vial and squishing it into a bag. That changes the volume of the bag. Volumes are additive. So if I said we're injecting this into a 1,000 milliliter bag, what's the volume before we add anything? 1,000 milliliters. What's the volume after we add something? The combined volume. So understand, we started with 1,000 mils, but then we injected 7 milliliters of amphotericin B. Then we injected 2.5 milliliters of heparin. So the bag is not a 1,000 milliliter bag anymore. It's a what? A 1,009.5 milliliter bag. So that is a key for a lot of these types of questions. So just remember, when you're taking an additive and injecting some dose into a bag, it's not just the weight of that drug that's going in there, it's the volume of the additive as well. So my argument here is when we do this infusion calculation, we got to take the total correct weight volume of the bag, which is 1,009.5, and divide it by the infusion time, which we said in the question. Make sure you realize where this came from. It's an 8-hour infusion, so based off of that, all you got to do is take the total volume here, divide it by the total time here, but then be careful, because what was the units it desired for? How many mils per minute? So the only trick is we're in mils per hour, so let's multiply by in 1 hour that there's 60 minutes, so that again, that cancels, and my final units are milliliters per minute. And if you do that math, you get 2.1 milliliters per minute. Okay? Biggest trick on that is remember to add your volumes together. When you're doing a total volume over a total time, the total volume will be everything that got squished into that bag. All right? Next question says, IV fluid of 1,000 milliliters of lactated ringer solution, or LR, was started at the patient at 8 a.m. and scheduled to run for 12 hours. At 3 p.m., 800 milliliters of the fluid still remained in the bottle. At what rate, now this is important, make sure you do this with all these questions, always circle what the final answer needs to be in. At what rate in drops per minute should the remaining fluid be regulated such that the IV delivers using a set that has 15 drops per mil? What's the rate in drops per minute? Okay, so that we get it done by the time it's supposed to be done. Okay? Now, to some of you working in a hospital, who've worked in a hospital, look at that question and are mortally offended by something that I did in that question relating to time. In a hospital, what do we never express time in? AM or PM. That's a terrible thing to do because things in the hospital happen 24 hours a day. So tons of mistakes have happened when something was given at 7 p.m. when it should have been given at 7 a.m. or something like that. Because of that, we never express time in AM or PM. We need to do it in 24-hour time or military time. So somebody tell me, what is the correct time for 8 a.m.? 800 hours, okay? So that, again, would be 08:00, okay? So again, and I guess I should back up on that in case you've never done this before, midnight. Midnight is what time in 24-hour time? 0 hours, 0, 0, 0, 0. So midnight is 0, which means at the end of the day, you're getting up to 2400. So it goes from 00 to 2400 before it resets. All right, so 8 a.m. would be 800 hours. What is 3 p.m.? What would 3 p.m. be? Well, it goes to 12, and then after 12, it's what? It doesn't go back to 1, it goes back, just add an hour to 12, would be 13, then 14, then 15, then 16, and so forth. So 3 p.m. is 3 hours after noon, so what is 3 plus 12? I would say that's going to be 1,500 hours. And again, if this was scheduled to run in 12 hours starting at 8 a.m., 12 hours later it would be what time? Do not say 8 p.m. See, 8 plus 12 is 2000. So it's supposed to be scheduled to run at 2000. Everyone okay with that? I'm just making a big deal out of it. Just realize that in a hospital, all time is always expressed by 24 hours. It's not done by AM or PM. Right? Now, I won't need that here in a minute in this question, but here's a little bit of a trick to this question. We've already done something. We've administered some amount of fluid in a certain amount of time, but that don't matter. What do we have left to do? Prioritize. How much fluid do we still need to administer? 800 mils. Are you with me on that? So where do you start with that? Let's start with A, what do I need to infuse? Right now, I need to infuse the remaining volume, which is 800 mils. How much time do I have to administer that 800 mils? Well, that's where we need to look. If it's supposed to be done by, everything's supposed to be infused no later than 2000 hours, then what time is it right now? It's 1500 hours. So what I have left to do is I have to have this amount of fluid administered in that amount of time. Do you see where those two are tied together? I need 800 mils in 5 hours. And what did we say flow rate is? It's volume per time. All right, so we have already a volume per time. What we need is 800 mils over 5 hours. The problem is what we want in the end is in drops per minute. So all we need to do is convert our units so that we take our 800 mils in 5 hours and get it into drops per mil. So how do we convert? This is important. This is back to that drop factor. How can you convert a volume in mils to a number of drops? By the drop factor. That's the part of the question. Remember, there is no universal size of a drop. The size of the drop depends on the set that you're using. So I'd have to provide that to you. Where did I provide that to you? Right here. I have to tell you how to convert drops to mil because it depends on the set that we're using. The set we are using provides 15 drops per mil. So if I multiply by that, then I cancel my milliliters and I'm in drops. Yay. My last thing is I don't want hours, so let's convert hours to minutes. So we'll multiply by 1 hour over 60 minutes so that those cancel, and my final units would be drops per minute. If you do that math across, you would get 40 drops per minute. Okay on that? You see where to use the drop factor and where that kind of plays a role. That's how you convert volume to drops. Okay? Infusion rates convert volume per time. All right, let's keep going. This is finally into a dosing one. This is one that finally gets patient specific because it says, at what rate, again, circle that, this is our final answer. What do we want it in? We want it in drops per minute. So what is the rate in drops per minute? Should a dose of 7.5 micrograms per kilogram per minute of dobutamine be administered to a 154-pound patient using a solution that contains 500 milligrams of dopamine in 250 mils, using a set that has a drop rate of 60 drops per milliliter. Okay, the drop factor is 60 drops per mil. Okay, this is patient specific now. So we want to calculate an infusion rate for this patient. The dose of the drug. Again, the volume will be based off of the dose that we need, and this dose for this patient is based, for dopamine, or dobutamine, I'm sorry, is based off of weight. So let's start with this patient's weight, all right? A patient weighs 154 pounds. The first thing we got to do is convert pounds to kilograms. So do you remember how to do that? You divide by 2.2, since there are 2.2 pounds per kilogram, that cancels them. Now I'm in kilograms. Here, if some of you, I can take a hint, this would be really helpful, learn to do this, because you will get a lot of questions that express things in micrograms or milligrams per kilogram per minute. Re-express that like this. So it is, in this case, micrograms in the numerator, but put the two other units together in the denominator. So I put it as 7.5 micrograms on top over kilograms dash minute, because we have two units in the bottom, okay? We're going to need to convert those units as we need, so make sure we cancel them as we go. By doing it this way, hopefully you can see that kilograms would cancel. And right now I would be in 7.5 micrograms per what? Per minute. Since I've canceled the kilograms, I'm now just in micrograms per minute. But I need to be in drops per minute. So the last thing I've got to do is convert from my weight of my drug in micrograms to a volume. Okay, the first thing is to get rid of the micrograms, since my concentration is in milligrams. So I converted micrograms to milligrams by essentially dividing by 1,000. That gets me milligrams. Now here's the deal. How do you go from weight to a volume? You use the concentration, all right? So right here, we're told the concentration of this is 500 milligrams of dobutamine in 250 mils. That's the information I'm going to use right here. And I set it up so that I put milligrams on the bottom so that milligrams cancel. And using the concentration now, I have converted from my weight of my dobutamine to my volume of the solution that I need. I'm now in milliliters per minute. The last thing to do is convert to drops per minute. And how do I convert from the volume to drops? I look at the drop factor. What was the specific drop factor that the set that I'm using here is 60 drops per mil. So I set it up that way so that my milliliters cancel, and I get 16 drops per mil. So again, if you look at what's left over, there's my minutes unit, there's my drops unit, so I'm in drops per minute, and do the math, and I got 16. Any questions with that? This is a good example. These are the very typical kind of questions you'll get asked a lot. And these are real practice-based questions. You'll look up I'll show you here in a minute, the next part of this question comes out of Lexidrugs. It's a different way of dosing it, but they would tell you this drug, a normal dose is 7.5 micrograms per kilogram per minute, okay? That's the rate at which you infuse it at. So let's do a little variation on that. This is because as you're learning your drug information skills, I'm going to show you how to do a lot of this dosing without having to do all that math. A little bit of math, but let's look up into Lexidrugs. Okay, let's do this. Using the table below, which I haven't shown you yet, what is the recommended infusion rate in drops per minute? Okay, so we're still doing the drops per minute. For this same patient, the only difference is instead of this bag, I'm not using this bag anymore, so let's use this bag. Can anyone tell me what the difference between those two bags are? They're both 250 mil volumes, but the amount of dopamine is what? Now only 250 milligrams. So I don't have 500 milligrams per 250. I have how many? 250 milligrams per 250 mils. How many milligrams per mil is that? 1, right? 250 divided by 250 is 1. And 1 milligram is how many micrograms? 1,000. I just want to realize the bag I'm using for this question now has 1,000 micrograms per mil. I didn't have to invent that. It's on the bag. It says it. It tells me that. Okay? Now I go to Lexidrugs, and they have a table for me that helps on dosing. But be careful, right here it says dobutamine infusion rate for the 1,000 micrograms per milliliter concentration. So this table only applies to the concentration of the bag that I'm using. If I were using that other bag, I couldn't use this table. All right? So what we need to do is start over here with our the dose. The doctor told me to give 7.5 micrograms per kilogram per minute. And thus, I just need to find the table with their weight. So 154 pounds divided by 2.2 is, anyone know, did you do that? 70 kilograms. So again, this is the column, this is the row. So if I make the meat in the middle, voila, there's my answer. My answer is 31.5 what? Milliliters per hour. Okay, so this is where you got to be careful. This table gives you an answer, but it's in milliliters per hour. So the last thing that you have to do is convert that 31.5. So does everyone see where that came from? That comes right out of the table, but you've got to be careful and use the values off the table. It says that number, 31.5, is mils per hour. So let's take 31.5 milliliters per hour and convert it to drops per minute. You can do either one first. I did the volume first since I was using the same 60 drops per mil set. I set it up so that my milliliters cancel, and now I'm in drops per hour. And to convert from hours, I will divide by 60 so that my hours cancel. And in the end, I get drops per minute. And if you do that math, obviously the 60s cancel, and you get 32 drops, rounding to 32 drops per minute. Everyone okay? All right. All right, I love this question. It shows you how tricky some of the product labeling is going to be when you get out there as a pharmacist. So I'll come back. This Toricel, or the temsirolimus, it's a drug used for advanced renal cell carcinoma, so it's an anti-cancer drug. And it's a drug, like a lot of drugs, that isn't stable in water. It breaks down, it hydrolyzes. So do you know to give it any sort of shelf life, they have to package it as a dry powder in a vial. And the powder, the drug powder in the vial, is this one here. So the powder is the vial there. But they supply it with this special liquid that you're going to use to reconstitute it. Okay, it's got the adjuvants in it. Have we talked about adjuvants and some other things? It's got some special formulation in it, but it's the fluid that we're going to then, when we need it, add to the powder drug so that we can administer it, but it has a longer shelf life. So the diluent is in this vial. All right, pretty straightforward on that. So my question is, reading that on there, we know on the right-hand side in the diluent vial, there's 1.8 milliliters of diluent. All right. On the left-hand side, it says there is 1.2 milliliters of powder in the vial, okay? And it says there's 25 milligrams per mil. So let me ask you, when you reconstitute, when you take 1.8 milliliters and inject it into this vial, how many milliliters will there be total? Remember, volumes are additive, so if you take 1.8 mils and add it to a vial that has 1.2 mils of powder in it, what's the total volume? 3 milliliters. What would the total amount of drug be? 25? Hold on a second. This is careful. This 25 milligrams per mil only relates to that amount of initial powder. So do me a favor right now. If you, knowing that there's 25 milligrams per mil and there's 1.2 mils of powder in there, how much drug is actually in that vial? It's not 25 milligrams. What is 25 milligrams times 1.2? That's 30. So there's actually 30 milligrams of drug in there that eventually will be reconstituted with how many mils? 3 mils. Because remember, adding diluent doesn't change the mass. So if there's 30 milligrams of drug to begin with, then when you finally add your extra liquid and shake it all up, there's still 30 milligrams of drug. But now the concentration is 30 milligrams of drug per what volume? 3 milliliters. What is 30 divided by 3? 10 milligrams per mil. So I just want you to realize that's kind of where this information comes from. But you can see how difficult it is sometimes to read and understand the products. Now we can go past that. It says you're going to prepare this by adding 1.8 mils of the diluent to the drug vial. That gives you 3 mils total and the concentration of 10 milligrams per mil. Now, past that. The required quantity is then added to 250 mils of sodium chloride for infusion. The recommended dose for this patient actually is 25 milligrams infused over 30 minutes. Okay? So if we prepare it the way it's stated, and given the dose that the patient needs, what is the actual final concentration in milligrams per mil? Okay? Are we going to put that whole vial into the bag? Is that what they told us to do? Because now you know there's how many milligrams in that vial? 30 milligrams, but the dose is only supposed to be how much? 25. So let's start with that. Okay, well, if I want 25 milligrams, then how much of this solution, once it's reconstituted, how much will I need? Well, take your 25 milligrams, which again comes from here, 25 milligrams, times the concentration of the additive, set up so that milligrams cancel. 25 times 1 milliliter over 10 milligrams gives me 2.5 mils. So out of that vial, I need 2.5 milliliters. Because that gives me the 25 milligrams I need to put in the bag, okay? But the 25 milligrams comes at what volume? 2.5 mils, all right? So we need to remember that what? Volumes are additive. So if I start with 250 mils and I inject 2.5 mils so that I have 25 milligrams, my total volume is now 252.5. Is everyone okay? I know that's not mind reading, but this is what I'll just remind you. It's important. When you inject 25 milligrams, you're not just injecting the weight of that drug, you're injecting the volume based off of its concentration. So you are also injecting 2.5 mils, so the total volume is 252.5. The final drug concentration would be then the total dose, the 25 milligrams that we have wanted, that we put in there, the weight of the drug, over the total volume. So again, the 25 milligrams is there on top, the total volume is there on the bottom. You divide those out, and it's 0.1 milligrams per mil, right? That's easy, right? There's no way anyone could screw that up with like 0.01 or something, right? Okay, no one watched the video, that's good. Let's move on. So let's go on to calculate the infusion rate for milliliters per minute. We have our bag. Now the nurse needs to know, because were we told this bag that has 252.5 mils and 25 milligrams of Toricel, it was supposed to be administered over what amount of time? 30 minutes. So that's the time that bag needs to go in. So all you need to do for a flow rate is take the total volume over the infusion time. Flow rate is volume per time. Now, double check, what units did we want? We wanted milliliters per minute. Luckily, our values here are milliliters, and we know 30 minutes, so we don't have to convert anything. So just take 252.5 divided by 30, and you get 8.4. All right, you ready? Keep going. This is a cool one. It's an easy one, just like we did with the dobutamine, except for it's a chemo drug. And not all chemo drugs, but some chemo drugs aren't weight-based dosing. They're based off of what? We've done a lot of these calculations. Body surface area. So the only trick to this is, do you guys still remember how to do body surface area, right? Right? Tell me, yes, please. Okay, let's do it. So I'll just take the time, I'll go a little bit quicker. Given the patient information, to do body surface area, we need the weight in kilograms. So let's take the patient's weight of 112 pounds, divided by 2.2 to get 51 kilograms. Weight to kilograms. We got to take their height, this is a little bit harder, to get it to centimeters. So let's take the 5 feet times 12 inches per feet to get essentially 60 inches. Now let's add the additional 3 inches, since they're 5'3", that means a total height of 63 inches. I do it in inches so that I can then take the conversion factor I can memorize, which is 2.54 centimeters per inch. Take the 63 times 2.54, that's 160 centimeters. Great, I got the weight in kilograms and the height in centimeters. Remember the formula? All I got to do is take the height in centimeters times the weight in kilograms, divided by 3,600, and then do what? Don't forget to take the square root of that. So the height times the weight, then kilograms and centimeters divided by 3,600. Take the square root of that, and you get the body surface area in units of meters squared. So you do that for patient, and this patient, and I get 1.5 meters squared. Okay? That's a kind of a review. You feel okay about that? We have done some body surface area calculations in the past. That's no different than what we've done. Now we can apply to the dosing. So we said for this patient that we have a specific dose for this drug. So let's take their body surface area, 1.5 meters squared, and then multiply it by the fact. And this is where I'll still tell you this whole idea about milligrams per meter squared per hour. Re-express that like this, where you have milligrams on top over metered squared dash hour. That way when you multiply here, you can see that metered squares canceled, and I'm still in milligrams per hour. But I need to get to drops per minute, so I got to convert milligrams to drops. So first thing I got to do is convert the weight to a volume. So remember, we convert weight to volume by concentration. I was given the concentration of this cytarabine as 100 milligrams per liter. So if I express it as 1 liter over 100 milligrams, I can cancel my weight, and now I'm in units of volume, liters, which I want to quickly convert to milliliters by multiplying by 1,000. And now how do I go from a volume to a number of drops? It depends on the set I'm using, and the set I'm using here has 20 drops per milliliter. So multiply by 20 drops per mil, and I'll cancel my mils, and I'm finally in drops. Yay! But I'm still in hours. Don't forget the hours. So to convert hours, I've got to multiply by 1 hour over 60 minutes. That's what leaves me my 60 minutes there and my drops per minute. So do that math across, and you get 38 drops per minute. Okay. This one is just like one of your homework ones, to be honest with you. I think the numbers are changed here a little bit, but let's just see if you flash back a little bit to one of your homework things. In this case, it says this patient needs potassium, the potassium ion, potassium, at a rate of 5 milliequivalents per hour. That's the rate. We want to give the IV fluid so that whatever volume you give provides 5 milliequivalents of potassium every hour. Okay? The solution, what makes this question difficult is I just didn't give you the concentration in milliequivalents or tell you how much potassium was in there. I said what we did is took 4 milliliters of this more concentrated solution, this 39.2%, which is shown there on the right, and diluted it to 500 mils, up to 500 mils. So this is the problem. This whole question here, and the same thing was in the homework, is you got to deal with this first, okay? This part here especially. You need to say, okay, 4 milliliters of a 39.2% solution is not helpful. What I need to know is actually how many milliequivalents of potassium did I put in the bag by doing that. So the first step to answer this question is to start with that 4 milliliters. I'm adding 4 milliliters of that concentration. Let me now figure out how much actual potassium is in the bag. From doing that, and I'll show you, I'll spend the time reading through all of that. My first step was to take the 4 mils times the concentration and convert it essentially into milliequivalents of potassium. Okay? So now that I know the total number of milliequivalents of potassium, I can deal with that because I know that's the amount of potassium that's in 500 milliliters, right? So that's my concentration. 16 milliequivalents of potassium per 500 mils. That's the amount of potassium. It's in a 500 mil bag. This is where I'm starting off. What I want is this. So let's start with what I want, which is 5 milliequivalents of potassium per hour. Let's multiply it by this concentration. So all I got to do is pull that over, and again, set it up so that my milliequivalents of potassium cancel, and I get milliliters per hour. So essentially, if you do it like that, you get 156.25 milliliters per hour. And the only trick was knowing to start by first taking all that information and turning it back to, well, dang it, how much potassium is actually in that bag? That's what it's dosed on. The infusion rate's based off of potassium. So how much potassium is in that bag? So that was really the first step on that. Okay? And this last question is pretty easy, but there's one last thing. I'm really running out of time here. So let me do this quick. It says, okay, the doctor wants 600 milligrams of dopamine in 500 mils of D5W. The vial we have to provide that has a concentration of 80 milligrams per mil. Well, if I want 600 milligrams, take the dose that you want, milligrams, times the concentration as 1 mil as 80 milligrams, so that my milligrams cancel. I need to add 7.5 mils. So this is the amount of that stuff I have to put into a bag. All right? So that's what I'm going to do. So down below it says, okay, well, from that 600 milligram per 500 mil bag, you want essentially 4 micrograms per kilogram per minute. So what is the actual infusion rate? So let's start with the weight. You start with the weight here, and then you're going to multiply by this. And I'm going to re-express like that. So 64.5 kilograms times 4 micrograms per kilogram per minute. That cancels the micrograms. Let's convert micrograms to milligrams by dividing by 1,000. Then let's take this concentration, this bag you just made, let's take its concentration and multiply it so that milligrams cancel, and I'm on milliliters. And the last step would be to take the drop factor here to convert it to the drops per mil. So I got 6 drops per minute. That's a pretty nice round number, would you agree? Now, are some of you unhappy though? Is this right? My last thing here, and I'll shut up finally. Is that really right? Knowing that we did this. Where was the 7.5 milliliters? Should it not have been 507.5 milliliter bag? If you start with a 500 mil bag and you inject 7.5 mils in it, what's the final volume? 507.5. So why didn't I do that in my calculation? You probably should in a calculations class, but here's the deal with practice. Let me ask you, we're trying to tell how many drops per minute. Is there that much of a difference between 5 drops per minute or 6 drops per minute? Is there much difference between 500 mils and 501 mils? Is that the same volume, really? 500, 501? What about 502? 503? At what point would you agree that the additive amount changes the total volume enough that, from a practical sense, we have to account for it? The amount of time it would take to administer this new volume would be significantly different. Therefore, we have to account for it. And this is where it's not a hard and fast rule. Institutions do this differently, but most places will argue about 10%. If you add more than 10% of your starting volume, then you have to deal with it. So let me ask you this. If this went into a 50 milliliter bag, what is 10% of 50 mils? 5 mils. Is 7.5 mils more than 10% of our starting volume in a 50 mil bag? Yes. Would we have to account for it? I'm saying absolutely. All right. This is just a practice thing here, but in a 500 ml bag, 7.5 mils is well less than 10%. So to be honest with you, nurses are going to be more likely to correctly program a pump to run at 6 drops per mil than 6.03 drops per mil. See what I'm saying? When we talk about rounding or talking about a degree of precision, we have to deal with human errors and deal with the fact that oftentimes institutions will want you to make this sort of decision. If it's not significantly a different volume, then let's choose the easier number to program. Let's do the safer number to program, because it's real easy to go 6.03 and turn it into 60.3. You see what I'm saying? Unfortunately, those errors have occurred. So in a real practice setting, we tend to decide when we really have to be so precise to account for that extra volume, and that's about 10%. Okay? I just had to say that because that is in fact what happens in most institutions. In a calculations course, you're probably safest to do what? Account for the volume, because you are right. It is really 507.5. It is additive. You need to know that. Whether you actually account for it or not is a practice-based thing from a calculation standpoint. Please remember, whenever you suck things out of vials and stick it into bags, that volume is in fact changing. You do need to know the real volume in that bag does change. So